Hello, everyone, and welcome to our webcast. I'm Amy Pendergrass with Moss Adams, and I'm going to get us started for today's session. Why auditing healthcare claims is paramount for payers. Before we begin, I'm going to play a brief video.
Welcome, and thanks for joining us. We're pleased to present another in our ongoing series of continuing professional education webcasts to help companies and individuals conquer challenges as they plan for what's next. Our presentation will start in a few moments. Before we begin, here are a few things to keep in mind. You can customize how you both view our presentation and interact with the presenter. For better viewing, close all other applications and turn up your speaker volume. You can also adjust window size and placement or enter full screen mode using the controls at the top of the window or dragging the bottom right-hand corner to resize. At the bottom of your screen, you'll see a series of icons, each relating to a different aspect of our session. You can download the group attendance sheet and a PDF copy of today's slides from the slide deck and handouts widget to the right of the slide view. You can ask our presenter questions during the webcast by typing a question in the Q&A window below the slide view and clicking submit. We'll do our best to answer all questions during the presentation or follow up via email. If you experience technical difficulty during today's presentation, refresh your browser by hitting the F5 key. Today's session will offer you 1 CPE credit. To receive credit, you must meet the requirements as specified by the National Association of State Boards of Accountancy. You must attend at least 50 minutes of the session and respond to at least 75% of the polling questions, which we'll ask throughout today's presentation. To respond to a poll, click the button next to your answer. We'll track your progress and alert you when you've earned CPE credit. You can then click the certificate icon in the CPE Progress widget to open a PDF file that you can save to your computer. Don't worry if you can't download your PDF certificate today. We'll email a copy to you in 2 weeks. If you're attending this webcast in a group, you must complete our attendance sheet to receive CPE credit. The attendance sheet is available in the slide deck and handouts widget. Please have all group members sign it and send only 1 sheet per group. Also note that CPE credit can be awarded only to participants registered as themselves and isn't available to participants who view the on-demand version. As a reminder, the presentation you're about to see isn't legal, investment, or accounting advice. We encourage you to seek the counsel of a professional service provider to apply this content to your specific circumstances.
And now I would like to introduce today's presenters, William Norris, partner at Moss Adams, and Francis Orejudoa, senior manager at Moss Adams. Their bios and contact information are located in your webcast console if you would like more information. And now I would like to turn the floor over to Will to get the presentation started.
Well, good morning and welcome everyone. Thanks for joining our webinar today. We believe that this topic of payment integrity is extremely timely and highly relevant in this pandemic era. And we're hopeful that you find the content informative and beneficial, and we're looking forward to today's session. So just touching briefly on today's agenda, we're going to start out by providing a quick overview of the employer health insurance market. We're then going to talk to healthcare payer operations and the concept of payment integrity. Francis is then going to get into a little more detail on the impact of COVID-19 claims and payment integrity. We will then move to the subject of fraud, waste, and abuse in the pandemic era. And we're going to end with talking to the best practices around payment integrity, especially as it relates to COVID-19 and fraud, waste, and abuse. But before we dive in, we're going to get to our first polling question so we get a sense for who's on the call. Amy?
All right, thank you. So our first question is, which of the following best describes your organization? A, healthcare payer. B, employer fully insured. C, employer self-insured. Or D, other. And we'll give you a few moments to respond. To respond, please click the button next to the answer you choose and hit submit. Also, I'd like to take this time to let you know if you do have questions for the presenters throughout the webcast, you can use the Q&A window in your console to submit those questions. And we will do our best to respond throughout the webcast. If not, we will follow up with you afterwards. And it looks like most have submitted, so here are the results.
Okay, so it looks like we've got a cross-section here of folks like we expected, predominantly a lot of employers, and specifically focusing in on a lot of self-insured employers, and I would guess that many of the fully insured are contemplating going self-insured based on what we're seeing in the industry. But good, so we got a sense of who all's on board here. So let's just give a quick overview of employer healthcare insurance coverage. And 92% of the U.S. population has health insurance coverage. And that is comprised of 56% that have employer-sponsored coverage, or otherwise known as private. And the rest is more of the public sector, Medicare, Medicaid, VA, and so on and so forth. Speaking in terms of dollars and cents for employer-sponsored health insurance, that amount was approaching $21,000 for a family of 4. As we know, that is constantly increasing. It's taken a little hiccup in 2020, but it's predicted to increase even further moving forward in 2022. And of that, employees are contributing about $5,600 in out-of-pocket costs, according to Kaiser. And again, that is something that is continually rising and is for sure a concern area. Here's just a quick graphical representation of what I just spoke to with a little detail, but more importantly is this next graph, which really just shows the evolution of employer-sponsored healthcare over the last 10 years and what the costs have done. With the premium increases you can see from 2010 to 15 to 20, and I'm sure many on this call have seen this, but this is meant to be somewhat of a primer. And then in the dark blue, you can see the employee contribution and what that has done. And I think it's interesting to note as we move on here, so those increases that you saw on the premium represent 55% over the prior 10 years. And on the employee contribution, that's about 37%. And I'll compare and contrast that with for inflation-adjusted income, which is 4% for that same period. So you can see the disparity there, and it is certainly of concern. So what have employers done to do this, to adjust and to attend to the cost curve and what it's doing? They put in short-term fixes like raising co-payments, deductibles, other out-of-pocket costs. They've modified coverages and benefits, and all of those are great. They are short-term fixes. They also do have the unintended consequence of disincentivizing employees for routine preventative care, which often leads to worse healthcare outcomes, as we know, and higher costs overall. Another tactic that employers are doing, especially as we were just talking when we looked at the composition of the employers on board, they're turning to self-insurance to help bend the cost curve. And that's good, and it has the desired effect most of the time, but it also increases their exposure to claims financial risk. So that's something to be concerned about if they're not staying on top of their spend. So now that we've provided some background on the employer health insurance market and its trends, let's talk about one of the key elements driving increasing healthcare costs, and that's the medical claims payment expense. Or said another way, the healthcare payment cycle between providers and payers and specifically focused on the payer. And so in order to understand that, let's look at the healthcare payer, and that's healthcare payer is how it sounds. It's that entity responsible for paying healthcare claims, whether it be an HMO or an administrator or a health plan. And their ultimate objective at the end of the day is to process claims timely, process within turnaround time targets, whether regulatory-based compliance or otherwise. And it's also to process claims efficiently as far as, minimal cost per claim transaction. Now, you notice what I didn't say, it's to process claims accurately and with accuracy. That's secondary to these other two items, and because of that, payers oftentimes don't get it right. And that'll be borne out with some of what we talk about here in a minute. And why don't payers get it right? Well, processing claims is very complex. I'm going to show you that in the next slide, but there's a lot of factors. There's product differentiation, many products out in the marketplace. There's a lot of change happening, which was exacerbated by the pandemic. It's just constantly in flux, and claims processing, quite frankly, is far behind many industries when it comes to sophistication. So here's where I was talking about. It's complicated business, make no mistake about it. And if you look at the life cycle that's shown down below, I'll just touch on this. But from the time a claim is received from a provider, there are numerous steps and checks and tests and verifications that must take place before a claim can be paid. Eligibility is verified, benefits are validated. It's determined whether the provider's out of network, in network, credentialed, is the service authorized. So you can just see that the entire process really leaves itself open for a lot of things to go wrong, and they do. And just very quickly, one of the last things I wanted to say on that last slide, many payers operate with an error rate of between 3 and 7%, and that has been proven, study after study. So that's a pretty significant error rate when all is said and done. So claims is a very messy business. The process of paying claims is messy and is fraught with issues. And that's why all payers of all types, they get it wrong a lot of the time. And so that's where the concept of payment integrity comes in. And this is something that I won't read it, but just recently came out from United Healthcare. And I guess to boil it down, what it's really saying is, payment integrity isn't just a fad or, a task to be done, a box to check. It's really a business imperative for the health of healthcare. So quick overview of payment integrity. And at its core, it's really the process of auditing claims to evaluate billings from and payments to providers. And this has been a long-standing challenge for payers of all types, as I mentioned. And some of the independent analysis out there and the statistics confirm that claims accuracy continues to be an issue. 1 in 5 medical claims are processing correctly. I mentioned before, 3 to 7% are inaccurately paid. And I'll say that our own experience in auditing claims for payers of all shapes and sizes are consistent with these findings. So because of that, payment integrity has really been high on the priority list for most payers in the last decade, and specifically since the ACA. And one thing to be said is, it's not, payment integrity doesn't just impact providers and, the financial piece. It also impacts employees directly. And I know Francis is going to speak to that, but as far as their customer experience. So that's an important thing to keep in mind. So with the onset of the pandemic, as you can imagine, it created significant upheaval to the healthcare delivery system. We've all heard about that. But what's a little less publicized is the disruption because of the delayed impact that COVID-19 had on the payer claims processing workflow, kind of behind the scenes, if you will. And some of those impacts we're going to really drill down here in a minute, but due to emerging services, new codes, new billing, constant change related to coverages and benefits. Francis is going to cover those two items, and then I'm going to tag on talking about fraud, waste, and abuse. So in summary, while the risks have always been there for claims processing errors and inaccuracies, but with the pandemic, it's been exponentially increased. So it's really imperative that payment integrity be at the forefront. So with that, I'm going to pass it over to Francis to get more granular with the impacts of COVID-19 and the processing of claims and its effects on payment integrity. Francis.
All right. Yes. Cool. Thanks, Will. So, Will just talked about the claims process and the need for payment integrity. And as, we saw, there's so many factors in the claims cycle. And we could also see how it could be affected, by any small tweak or wrinkle. And you can suspect, right, with the COVID-19 pandemic, it had its effect on payers and claims processing. When you think about the millions of transactions that payers process and the billions of dollars paid each year to healthcare providers, there was definitely a significant disruption that was caused by COVID-19 related changes on payers. And as Will showed in that slide, the claims process is already complicated as it is, without significant disruptions like COVID-19. But because of the pandemic, payers had to make updates in their systems and processes that they were just not anticipating in 2020, and they took place in different forms that we're just going to look at in the next few slides here. So the first area that we're going to talk about that was affected by COVID-19 relates to changes in benefits and coverage. I think we can all agree that last year was challenging for everyone. And for everyone, we can agree that the main priority was and continues to be about ensuring that people are safe and healthy. And to ensure that people are healthy, people needed to get tested, right? Testing was critical for that, and continues to be. And so to that end, we saw that coverage for testing services expanded with the Families First Coronavirus Response Act. It started requiring that insurers and payers waive cost sharing and prior authorization requirements for COVID-19 related testing. These provisions were so important so that people could seek evaluation for exposure to COVID-19 or if they themselves had symptoms. And reducing cost sharing, so when we talk about cost sharing, we're talking about co-pays, deductible amounts, co-insurance amounts. By reducing cost sharing, it meant that there were less obstacles to getting important testing services. In addition, many plans expanded coverage to inpatient admissions and outpatient treatment, which meant that for all out-of-pocket costs, whether at a provider's office, urgent care, ER, those costs were waived. And that was at some plans, not all plans, but some plans. And that was through, different periods of time that for most plans we saw ended sometime earlier this year, depending on the plan. And then also, many plans expanded coverage for telemedicine, including telehealth services related to primary care, but also behavioral health, right, and mental health services. And so we saw that this was super important so that people can get care while being safe at home. So all of these changes and expansions in coverage were critical so that no one affected by COVID-19 would be hindered in receiving treatment or care. All of these were super important to ensuring that people seeking care could get care. Getting testing and care for people was and continues to be the ultimate priority, no doubt. But it is worth noting that on the back end, in order for all these things to be sorted out from an insurance perspective, it took a great effort to implement in the claims process. Installing these changes to plan designs requires system reconfiguration, developing workarounds, sometimes creating makeshift processes in order to push these benefit changes through. And I'm seeing and we're hearing that many plans continue to make adjustments, so this is an ongoing effort. Reconfiguring thousands of benefits plans for some payers was a significant endeavor that took time and resources. And with these changes, it just creates opportunities or potential errors and threatens payment integrity. And so we know that errors create financial risk to the plan, and there's definitely a dollar risk. But it's not only the financial risk. There's also errors affecting the member experience. Last year was difficult enough, and we know that there were many challenges in just getting testing and treatment. So when provider bills came in and members were finding themselves having to pay for services they were not expecting to pay for, it just made things worse and created negative member experiences in an already challenging time. So on the last slide, we talked about the effect of making changes to benefits and coverage. Here in this slide, we observed that the differences, the various ways with how members were tested and treated at a medical provider made things even more complicated for payers in the claims process. And there was even a health affairs article that was published that described this at length last year. So depending on the nature of the evaluation for COVID-19 and the member's insurance coverage, members could have been subject to cost sharing for their healthcare visit and for any alternative diagnosis, even when they were not expecting it. So we see that here in this table. So in this first scenario, if a patient was evaluated in person and received COVID-19 testing only, the patient was liable for any cost sharing. Insurance should have covered all costs for that visit and testing. And then the second scenario, if the patient was evaluated in person and underwent testing for other diagnoses like flu tests or pneumonia, but not for COVID-19, cost sharing should have been imposed for the visit based on the benefit plan, right? So I think those two scenarios are pretty straightforward. If there was a COVID test, there's no cost sharing. If there's no COVID test, there is cost sharing. But it's in that last scenario, the third scenario, that causes problems. It created problems for payers. Because in this third scenario, if the member went in for testing, for COVID testing, and also got tested for other diagnoses like the flu or pneumonia, there would be no cost sharing for the COVID-19 test, but there could be cost sharing for other testing and services. It really just depended on how the provider billed the claim, and it was unclear, and it is unclear. And we've seen it handled very differently among different payers. And later we're going to get into a specific example of this and how it affected the member, and it led to a poor experience for them. In addition to modifying benefits with COVID-19 as a new virus, the CDC issued a new diagnosis code, and the AMA issued new procedure codes for testing and vaccines. So here are some of the testing codes that we're all, gotten to know and gotten familiar with. If you got a COVID-19 test last year, you may have seen these already in your plan benefits or in your explanation of benefits from your plan. So the effect of payers is this, right? So in order to process millions of COVID-19 related testing claims, they needed to determine the capacity and timing for updating their claims processing systems to accept, to receive, and process claims submitted with these new codes. Again, remember, the payers, they were not expecting to install these new codes. And as mentioned before, with benefits coverage, some payers needed to establish manual processes and temporary workarounds. So depending on the complexity of installing these codes, we have seen some payers even needing to add staffing to ensure that manually processed claims are handled properly on a timely basis. On this slide, we just share a listing of the different vaccine codes, and you will notice that there are different codes based on the different manufacturer. And also with each vaccine code, there are administration codes that accompany them for each dose, right? So we're all familiar with the Pfizer vaccine and that there are multiple doses. And so with each dose, there is a separate administration code, a unique code for each administration. So here we're just illustrating that, there's new coding needing to be installed. And what we've heard, with the implementation of the vaccine codes, that these have gone smoother than the testing codes. And we're not hearing of any people being charged for vaccines, at least firsthand. But it's interesting, as we were preparing this, because there was a recent letter, I think it was just even this past week, where President Biden was calling out insurers for billing for COVID vaccines. And this was just in the last week. So it appears that there have been some problems associated with health plans and insurers providing coverage for vaccines. So more work needs to be done on this front. In addition to modifying benefits and installing new codes, there was also the implementation of certain benefit exceptions that had an effect on claims administration. So we saw that plans changed how benefits were applied to non-network providers for COVID-related services. We have seen payers equalize out-of-pocket amounts for COVID testing across in- and out-of-network providers, meaning that they offer the same coverage for out-of-network than in-network providers. And we see that many plans cover COVID testing at 100%, regardless of what network arrangement the provider has, whether they're in or out. So this is a big deal for payers because a provider's network status is a key element in the claim cycle. If a provider's network status is out of network, then it usually affects all the benefits for that one provider, where there is less coverage to the member compared to if they're in network. And it gets complicated when then a payer has to treat one specific benefit uniquely, differently than the rest. It takes a lot of precision in the system programming to ensure these claims are processed correctly. And again, sometimes human intervention, manual processes are needed, and if the programming is not correct, then it can result in a lot of mispayments and errors. Payment rules, we observed one particular change specific to inpatient claims that affected some payers we observed. As a result of the CARES Act, inpatient claims for an individual diagnosed with COVID-19 had a 20% increase in their reimbursement. And so I think most of us know that this rule was directed for Medicare and Medicare-related claims. But many commercial hospital contracts are based on Medicare rules. So providers in a commercial arrangement would be getting this 20% increase if they contracted with a payer that's paying based on Medicare rates, right? So in order to receive this pay increase for this inpatient claim, providers have to meet two requirements. A provider must bill with a COVID-19 diagnosis, and then after September 1 of last year, a positive lab test must be on the patient's medical record. So, the federal government, the CMS, they already indicated that they're going to conduct post-payment retrospective reviews to confirm that these two requirements are met, that there's a COVID-19 diagnosis and that there's a lab test. And they've come out and said that they're going to recover on this 20% increase if those requirements are not met, right? So it's worth mentioning that if the federal government is performing these tests, that all payers who are paying according to Medicare rates should be ensuring these requirements are met to confirm that they're making the correct payments. You can suspect that there are many overpayments being made as this rule change is not properly implemented across different payer operations. And last year we talked about inventory spikes. It's just worth mentioning that in general, claims administration can be disrupted by changes in transaction volumes and processing efficiency. So under normal conditions, without a pandemic, payers, staff for a predictable volume of claims and actively manage claims inventories to achieve a consistent throughput and production. Changes in the volume of claims can sometimes require manual handling when there are surges in inventory. And so, we see that in the past year, because of COVID-19, there were definitely surges in volume. And that was because of, we all heard and saw that there was deferred care, right? 1 in 10 decided to postpone care. Many didn't have a choice simply because elective procedures were delayed. So, just as we mentioned with the introduction of new code sets, modified benefits and coverage, changes in provider network rules, payment rules, also the effect of deferred care resulted in an increase in the volume of claims requiring manual processing. And with increased volumes of manual claims, inventory spiked, and the overall process of adjudicating claims is impacted. So, we just talked about various issues we've observed in the past year brought about by COVID-19 and its impact on claims payers. It looks like we have our next polling question. Amy, can I have you take that?
All right, so our second polling question. My administrator has kept me up to date with their plans for adjusting to COVID-19. A, strongly agree. B, agree. C, disagree. D, strongly agree or disagree. And E, I don't know. And you will submit your answer directly on the slide. So select the answer you choose and hit submit. If you can't see the submit button, please enlarge your slide area. And then also as a reminder, if you would like to receive CPE for today's webcast, you will need to respond to at least 3 of the 4 polling questions. Leave this up for another 5 seconds or so. Okay, here are the results.
All right. So it looks like for many of you, about 39% of you have your administrator keeping you up to date, which is fantastic. It shows that your administrator has been working with you, reporting with you, and being proactive and sharing with you their updates for adjusting to COVID-19. That's great. We know that there are some where payers are still scrambling and they're trying to manage those changes. So it wouldn't have been a surprise if there were many. It's not a surprise here that some see where there could be a delay in that communication. But for those here, where they can agree that many have been kept up to date, that's fantastic and reflects strong practices from the payer, for sure. All right. So here we're going to get into some examples of where we've seen claim payment errors in light of the changes that we were just describing. And we're going to get pretty deep into claims, but it's really where the devil's in the details. So we just want to highlight some errors that we've seen particular trends. So in this first example, it's pretty straightforward. A member came in for a COVID test and was charged a $50 copay. We see the COVID test. It's the code 87635, which is a PCR test. And so we know that insurers were not supposed to charge copays for testing. And when we tried to understand why this happened, we got an interesting response. The payer said the provider did not bill this claim with a COVID-19 diagnosis, right? So that was their argument for why they charged a copay. And it points back to the different ways providers bill and its effect on reimbursement. And so going back to the payer, they said that they built their systems to only waive the copay if a COVID-19 diagnosis was present. However, there is no regulation, there's no payment rule, and there was nothing specific in the benefit plan that indicated that a COVID-19 diagnosis was needed. There are rules about medical necessity, but not specifically about a COVID-19 diagnosis. So there was no basis for the payer to build this logic into their system to only waive the copay if a COVID-19 diagnosis was present. And so ultimately, this claim was determined to be an error. And you can suspect, right, that there are many other claims where the payer charged member COVID tests if providers did not bill a COVID-19 diagnosis. And so we're actually working with the payer now to perform this analysis and to vet this out. In this next example, here's a situation where a member was charged for an out-of-network claim. So for this member, it's the daughter of the insured. They went to a provider to get a COVID test, and we see the test there, 87426. It's an antigen test, and again, this member was charged a copay. But the reason why they were charged wasn't because the provider did not include a COVID diagnosis, like in the last example. There was a COVID diagnosis. But the payer charged a copay because the provider was out of network. And you can see that at the bottom, right, on the remarks. They point out the provider is out of network. And if you remember, right, during this time, this is when, COVID tests were scarce, and it was really difficult to schedule an appointment to get, the test, and it was hard for that member to find a testing site. And, based on the payer, they did recognize they were supposed to make exceptions to out-of-network claims for COVID testing. So in this case, the payer just made a mistake on the coding of this exception in their system. But the kicker is that they didn't volunteer that. They didn't volunteer that they made the mistake, and it was only because the member caught it. And so the member complained to their plan, and then their plan advised them to appeal, and then the member had to compile all this documentation and submit the appeal, and wait a number of months for the appeal to be judged and reconsidered, and ultimately, after just many months, the copay was finally waived after the claim was reprocessed. So this was an error again. And you could see, though, that, the dollars may not be massive. This is not like a $10,000, $20,000 claim. But, the member complained. They had to submit the appeal. They had to go through that whole process. And no doubt they were upset. And it affected their whole experience. And you can imagine how frustrating it was for the member to go through this, again, through already a very difficult time, for them and for everyone. On this last example relating to cost sharing, this was one that was reviewed multiple times because it was initiated by a member complaint about being charged co-insurance for a COVID test. So in this case, the member came into the ER. The member had different tests. They had a COVID test. You see the 87426 antigen test again. And they also had flu tests. And when the payer reviewed this, all they saw was an ER claim, right? And so to get really geeked out on, coding, there's a revenue code there at the bottom left, 450, that signifies it's an ER service, right? And so, for this provider, there's a contract with the payer to pay ER claims at a flat rate, okay? So the payer sees this, they see it's an ER claim, and they just know to pay a flat rate. But per the plan's benefits, the member recognizes they have a responsibility to pay a copay and coinsurance for ER services. They are rightly responsible for cost sharing for the ER services. But what the payer did not take into account was that there was a COVID test rendered. And based on the plan's intent, the member is responsible, yes, for the ER visit, but no, not for the costs associated with the COVID test. So ultimately, the claim was reprocessed so that the member would not be responsible for the COVID-19 charges. So, we point this out here, and this is a unique situation, but, we say it's unique, but, with the number of, ways in which, members, do get tested at providers, we see that this, is a trend where, this is a scenario that happens, quite often where even the payers themselves are unclear on how to interpret this. And, with different payers, there's different interpretations where some payers we've seen not charge any cost sharing at all, including the ER services because of the presence of the COVID test. But some payers, like in this scenario, they charged the whole service as usual to the member and did not account for the COVID test at all. So there's a lot of variation, and it's just important to determine what the actual intent of the plan is and how it's implemented. And some plans are very broad in their coverage intent, while others are narrow. So it's critical to confirm that what the plan has intended is being processed accordingly. And again, not a great effect on the dollars, not a big dollar claim, but no doubt it has an impact on the member experience. Okay, so here in this last example, the prior examples had to do with the members really bearing the brunt of the errors. In this case, it had to do with a self-insured employer, and the brunt is really taken upon them because this was an overpayment. And because it's a self-insured employer, this error affects them because they hold the financial risk. They're the ultimate payer. So in this case, this is an inpatient claim where the payment was just calculated incorrectly. There's a 20% increase that should have been applied, and it was applied twice. And the claim was overpaid by about $9,000. So recall previously that we were talking about how claims with a COVID diagnosis, they have a 20% increase based on the CARES Act. And in this case, the claim was manually processed. So there was a workaround needed because the payer didn't have the resources at the time to automate this pricing. And so instead, it required an examiner, a human claims processor, to use a pricing tool to determine how much the claim should be paid to the hospital. And the claims examiner manually added a 20% increase to the pricing result to account for the CARES Act incentive, or so he or she thought. Because what they didn't realize was that the pricing tool already includes the 20% increase, and this pricing tool actually comes from CMS directly. Anybody can access this. It's public on their website. So, we saw this one error, and we were able to find that it's not only this one, but that there are many others for the same payer, and that it affected many other plans. So This was discovered in a very short time, and we're in the process of performing a deeper dive into the full magnitude of overpayments for this payer. So, again, these are real-life examples of payment errors that we have observed, and I think, Amy, we have our next polling question.
All right, thank you. So our third question is, I'm aware of claims issues affecting my claims administrator related to COVID-19. A, agree, B, disagree, or C, I don't know. And for those of you that would like a copy of today's slides, you can download them from the folder that says slide deck and handouts. We will also be sending them out tomorrow along with a recording of the webcast. All right, most have submitted. So here are the results.
All right. So I think this is consistent with the prior polling question. It looks like most of you are aware of the issues that are affecting your claims administrator related to COVID-19, which is fantastic. And I know it's slightly in favor of the agree, and then there's some that disagree. And so it's not surprising. We do know that many administrators are again scrambling with having to manage some of these issues. And I would imagine too, for those of you who are being communicated the different issues, it's just worthwhile bringing up some of these examples, with them because, some of the things that we've seen the payers themselves were not able to catch, and they're very obviously nuanced. So it's just worth bringing up as a discussion point. And we know that for many payers are welcoming, feedback. They're welcoming, feedback from their partners to see, if they've caught the nuances so that they're processing claims correctly. So even if you are aware of all the issues, it's worthwhile just bringing up feedback for them to properly process claims on your behalf. All right. Next, I think Will is going to finish out here and talk about fraud, waste, and abuse.
Yes, thanks, Francis. And so Francis was able to demonstrate kind of the upheaval and disruption that payers are feeling, specifically in the weeds relating to billing and coding and its effect on payment integrity initiatives. So what we're now going to dive into is the other area that has been heavily impacted by COVID-19, and that's fraud, waste, and abuse in the pandemic era. So give a quick little overview, probably fairly self-explanatory, but nonetheless, fraud is, by its nature, intentional deception and misrepresentation of fact that can result in unauthorized benefit or payment. On the flip side, abuse are actions that are improper, inappropriate, outside of medical acceptable standards of professional conduct or medically unnecessary. And waste is waste. Not much else needs to be said on that. And some of the historical categories of fraud, waste, and abuse, and I'll probably be referring to it for brevity's sake as FWA moving forward, but billing for services that have not been received, have not been rendered, are not documented. Inflated, exaggerated billing for services provided, that upcoding, would fall into that category. Unbundling of services, performing medically unnecessary services, which is scary because not only is that financially fraud, but puts the patient's life in jeopardy or potential for injury. So there's a lot of categories that are out there, and a lot of the larger payer organizations, to be sure, have sound FWA programs in place, and some of the things that they're doing extensive data mining and analytics, like they're looking at different sort of provider billing patterns to see any sort of anomalies or exceptions. They're taking those billing patterns and they are comparing that to their peers or to a certain market. They're utilizing any and all tools available, whether for auditing claims in high volumes, use of claim editors, scrubbing software and scrubbing applications. There are a lot of things that are being done there now. Those are the more sophisticated payers. Some of the smaller, maybe mid-sized payers, may not have the infrastructure to perform adequate fraud, waste, and abuse detection. So therefore, the employer, especially the self-insured employer, is significantly at risk since they're paying dollar for dollar for their claims. So give a little sense of the magnitude of fraud, waste, and abuse, and depending on what source you go to, it's a little bit all over the board, but bottom line, it's very large. The National Healthcare Anti-Fraud Association, which is kind of the benchmark, they've estimated that 3% of healthcare spending is impacted by fraud, waste, and abuse, about $100 billion annually, and that's on the lower side. The government entities, law enforcement, think it's closer to 10%, 300 billion. I've seen studies that estimated at 800 billion. I guess at the end of the day, it's a very, very large problem. It's pervasive. And, for employers, healthcare fraud and abuse, at the end of the day, it increases the overall cost of doing business, and which inevitably translates into either higher premiums for the member, increased out-of-pocket expenses, and or reduced benefits or coverage. So again, it can get right down to the individual employee as far as the impact. Here's one of those other studies that was a little more granular, but again, I think just shows the different buckets and categories of fraud, waste, and abuse. Everything from, failure of care coordination, pricing failure, which is something we deal a lot with just as far as, correct application of fee schedules and contracting rates. And this is from the AMA. They're estimating in the mid 200 billion just for that alone. You've got fraud and abuse and administrative complexity. Again, suffices to say it's a massive, massive problem. Here are some of the headlines in 2020 that really spoke to that. These are some of the top ones that are out there. Everything from, you see in the middle there, telemedicine company, at a $56 million fraud conspiracy. Obviously, that has some relevance to what we're talking about, COVID-19. But then there's another here for a $1.4 billion fraud scheme that was uncovered. And I think in this one, there were 300 some people that were charged. And we're hearing about these all the time in the news, but it's big business. There's a lot of the fraudsters are out there. But as we'll now see, the pandemic has really amplified that. So in the era of COVID-19, fraud, waste, and abuse has really increased and been, like I said, amplified. It's increased the possibility and opportunity for bad actors to commit, fraudulent and abusive activities. No other way to say it. And also because of the upheaval and disruption to what we were talking about before, the healthcare revenue cycle, it's created whole new areas of waste and massive amount of waste. And this uptick in fraud, waste, and abuse is driven by a couple factors, some of which we've already talked about, the rapid introduction of new services, treatments, service setting, the corresponding changes in billing and coding guidelines and regulations. But something that's a little less talked about is you have all this change and upheaval, and then you layer on strained provider resources on the front lines and in the back office due to significant patient volume variability. that we've all heard about. You know, we have some parts of the country that are completely overwhelmed and some that are, you know, ERs are 25% full. So a lot of flux there. You have strained payer resources due to claim volatility because patients aren't coming in. And so what you have is that because of all this flux, the inability to really properly train employees and stay current and stay on top of things. We're hearing from a lot of clients, they just resorted to processing claims manual because by the time they made a change in their system relating to configuration, that was changed again. And so they just were processing claims manually, which created a lot of errors, which created backlog. And they were just trying to get claims out the door. So a lot of fallout. And so to get a little more specific on that fallout, here's some examples. And I really want to just zero in on the first one, telehealth. There were 144 new CPT codes introduced for telehealth alone. Francis was talking about testing and so on and so forth, but just telehealth. And there are now 270 new total related services. So again, a lot of variability, a lot of change happening. We talked about the treatment misrepresentations and diagnosis misrepresentations, massive coding irregularities, especially when it comes to labs. So all this uncertainty created opportunities for, you know, the fraudsters out there to really take advantage of it. So here's some of those examples that are in the news. You know, a little more narrow. They're fraud, waste, and abuse, but they're directly related to COVID. And I won't go into great depths here, but I think that just that first bullet alone, DOJ combats COVID-19 fraud, unprecedented pace and tempo. That says all you need to really know as far as the volume that fraud is happening. That second bullet is, again, another telemedicine fraud scheme that was uncovered, $143 million. And the list is so long. We just picked off a few here, but it's going to get even more, unfortunately. And that's why you have this next slide where the DOJ and OIG have really announced kind of their intention to go at this hard. And just like Francis was mentioning earlier, what they're really going to focus on is potentially all these members who maybe providers were hoping to get that 20% kicker and coded the claim, the billing with COVID-19 when in fact that was not legitimate. So they're going after that. They're going after the lab add-on testing that was happening pervasively. They're going after the issue between home health services provided as telehealth and vice versa. And I think that the common thread through all this is, so this is the government going after, you know, primarily the government payers. But the same applies in the commercial sector. These same issues are there. So the same amount of rigor and diligence needs to be put in place as it relates to payment integrity. And so for everybody on the call here, in the webinar, you know, employers, you want to have this same amount of oversight because the fraud, waste, and abuse is indiscriminate and it's cutting across all lines of business. So it looks like we have another polling question here. Amy, do you want to take this, please?
Sure. Yeah, so our last question is, I have confidence that my administrator is on top of their FWA program and is focused on minimizing our exposure to claims overpayment. A, agree. B, disagree. C, I don't know, but I have not inquired about this information. D, I don't know, but I plan on inquiring about this. And once you've completed all CPE requirements, you will be able to download a PDF of your certificate from the CPE progress window. And we will be sending that out within a couple weeks if you have difficulty downloading it now. We'll leave this up another 5 seconds. Okay, here are the results.
Great, thanks, Amy. Interesting, some of the responses here, and I really like to focus in on D, and that's the intent of this presentation in general, is if you aren't aware what your administrator or what your payer is doing about this, and hopefully you come away from this wanting to know and asking about that and having them provide you with some evidence and demonstration that they are on top of this, because this is a big area, and like I said, this flows all the way down to the employee when there's that financial exposure due to fraud, waste, and abuse. So we're getting towards the end here, and what we want to end with, we're presenting not a very rosy picture, and we know that. So, what's an employer and a payer to do? And it really comes back to that payment integrity. And what are the best practices that we've seen out there? What are the countermeasures that payers are putting in place as it relates to COVID-19 and fraud, waste, and abuse? And this is just what we've seen, certainly what we suggest and encourage employers and payers to do. You have dedicated COVID-19 teams that are monitoring updates, staying on top of the changes. We have a couple clients where they really were emphatic about having a single source of information and staying on top of it, and that really served them well. Heavy emphasis on robust claims auditing protocols, and from our definition before, that is payment integrity. And you can have prepayment audits, post-payment, random sample, statistical audits, targeted category-based audits, electronic analytics, the best in class of our clients as far as payment accuracy. They do all these things, and they do it well, and they do it without fail. So there's no amount of payment integrity initiatives that are too much, especially with all the opportunity for financial exposure. They also develop performance standards and industry metrics. It's not enough to do all these audits. You want to measure them against something so you know where you're at. And you want to have reliable and actionable reporting. You want to, not only do you want to do all this audit and have standards and comparability, you want to put it out there in lights. So what we're hopeful for is payers, for their employer clients, that they provide this information as far as report cards or dashboards. And that's what we see the best in class doing. So, and here are a couple other ones, but I know we're getting to the end. Root cause analysis, I guess at the end of the day, you want to audit, but you also want to find and prevent errors from happening in the future. So you want to have root cause analysis and implement corrective action. So with that, we're at the end of the presentation, and we hope you found that the webinar was informative and come away with a renewed sense of the importance of payment integrity. Thank you all for joining us today, and I'll turn it back over to Amy to close us out.
All right, thank you. And thank you, Francis and Will, both of you, for a great presentation today. And thank you to our audience for your participation and for submitting all your questions. I know we didn't have time to get to those, but we will do our best to follow up with you after the webcast. Also, feel free to reach out to our presenters if you have additional questions. And as a reminder, if you attended today's presentation in a group and would like to receive CPE credit, you must complete the group attendance sheet found in your console. And if you participated as an individual and met all requirements, your certificate is available to download now in the CPE progress window. I will keep the webcast console open for a few minutes to give you time to download. Also, here is a link to an online survey for today's presentation. Please take a moment to complete this survey, as your feedback is very important to us. Thank you for joining our webcast. We hope you'll join us again next time.